presenting with us today. And for those of you that haven't met him before, you're missing out on the pleasure of a person. But Marcos is a medical doctor in the north of Brazil, and he's going to be presenting some work that's from that region on some topics that I cannot explain very well, so I'm going to leave it to him. But it's all to do with neurodevelopmental outcomes from congenital Zika, which you don't hear a lot about lately, but obviously was big in the news several years ago, but that doesn't mean it's not still around. So I'll turn it over to Marcos to share. Thanks, Marcos.
Thank you so much, Ashley. I will share my screen. Okay. So today we will discuss about that paper. It's a published paper called Continuous Epileptiform Discharge are associated with horse neurodevelopment finds in a congenital Zika syndrome prospective cohort. This study was conducted by UFMA, is the Federal University of Maranhão, a state at the Northeast in Brazil, and also with collaboration with the Global Health Institute. So this is the published paper that was published at the Caesar Journal. Is one of the most important journal of neurology, and it's available to read. Just a contextualization about the Zika infection. It's an infection that was spread in almost all countries. We had cases of Zika virus, and is an infection transmitted by a mosquito, Aedes aegypti, that cause fever, articular pain, skin alteration as rash, for example, red eyes, and snow when occur infection during the intrauterine period can cause congenital Zika syndrome. And in Brazil, we had a lot of cases of congenital Zika syndrome, especially at the northeast region in Brazil, and where the study was conducted here, where I'm showing in Maranhão. We had a lot of cases. And the congenital Zika syndrome is a severe congenital disease that is known by the microcephaly at birth or after the birth and other neurological problems. So congenital Zika syndrome is a severe condition caused by intrauterine exposure to the Zika virus and represent a higher mortality rate when compared with children without the syndrome. There is a big chance to death at the first years of life. And some clinical characteristics of congenital Zika syndrome is the epilepsy and motor impairments. And at the context of the epilepsy, we have some patterns like the continuous epileptiform discharge, SEEDS, that was described in only one paper, previously paper, before our paper. Just one article showed the presence of the seed in the congenital Zika syndrome. And our hypotheses were are seeds in children with congenital Zika syndrome associated with worse neuromotor development and more severe epilepsy. And to answer that, we conducted a prospective cohort study with children with congenital Zika syndrome who born between 2015 and 2018 and followed up at the NINAR Center. NINAR Center is here at the image, is a referral center of neurodevelopment in Maranhão and assistance in rehabilitation of children. We included children up to 36 months of age diagnosed with congenital Zika syndrome and had correct monitoring with at least two EEGs, electroencephalograms. And each children was followed up every 3 months. So some variables collected. We collected information about the epileptic seizure, neurological symptoms, and neurological signs. We performed the EEG or video EEG schedule every 3 months or less time, depending of the indication. And the SIDS has a specific definition on the literature that is very technical, but just to know, it's a graph element with repetition of relatively uniform morphology and duration. This is very difficult to understand, but here is an example of an EEG with seeds, and here an example with a normal EEG. And we can see clearly that we have big waves, large waves, and this is epileptic pattern, and here is normal. So the children were included at the seed group if they zip this seed before 24 months old. So if they had the presence of seeds before 24 months of age, they will go to seed group. And important definitions as outcome, we have the drug resistance epilepsy that is defined when the child use at least two or more protocols of anti-seizure medication, but has failed to control the seizure. And we collected also the history of Zika virus infection during pregnancy, microcephaly at birth or after birth, neuropsychomotor development, gestational age, head circumference, age, weight, length at birth, and up to 36 months. When we also performed the computed tomography of school and classify the findings as mild, moderate, or severe. We have a specific scale to classify that, and we evaluated the gross motor function using the GMFCS scale. And we also performed the ocular evaluation. Here is just the definition of the diagnosis of Zika syndrome, but summarizing is we have a serology, a positive serology, or a very suggestive clinical case of congenital Zika syndrome, but all our children had phenotype specific for congenital Zika syndrome, or CT finds very suggestive of congenital Zika syndrome and microcephaly at birth. We had data collected at birth, 6, 12, 24, and 36 months. Some children, only two, was excluded because they had a different aspect of the Zika syndrome with hypertensive hydrocephaly, and we excluded that children's. And we stored the data at the RedCap and use R to perform the Fisher-Zecke test to see the association between categorical variables, make NIMR test to compare paired information of the children during the progress of the EG, student test to compare some anthropometric data, and we performed also the Kaplan-Meier curve to use it to estimate the first epileptic seizure. About the results, we included 75 children from 110 children who is followed at the NINA. 75 has the correct, adequate EEG monitoring and didn't lost the follow-up. And the seeds were identified in 41 children of them. And the mean of age of seed identification was 20 months of age. The most case occurred in both sides of brain, so also bilateral seeds. The most case were in both sides of brain, but we have in any side. When we compare the presence of seed in the group, no and yes, we can see association. We didn't see association with sex. PRNT is the serology for Zika and modern symptoms. We don't have association here. But when we see the presence of birth microcephaly, we can observe the presence of severe microcephaly is more frequent in the group uh, of SID. Also, when compare the first seizure age, the children with SID had the first seizure before 6 months. In the other hand, they began the seizure very early. The presence of drug-resistant epilepsy was also seen with more frequency, 74% compared to 26% at the seed group, and severe alterations in the eye, the retinal. We had more frequency at the seed group. Uh, Also, diverse symptoms, neurological symptoms as continuous cry, irritability, sleep disorder, dysphagia, we had more frequency at the SID group. Also, the CT alterations, we have severe alterations, more frequency at the SID group. But for the gross motor function, we don't have association. But this is important that all the almost all the children was at the 5 group of the GMFCS. That 5 group is a very impairment of the motor function. And in other hands, all the children were very severe. When comparing some anthropometric measures, we can see here in that box plot in red the presence of the SAD group. And here, for example, we have the head circumference. We can see at the birth, 0 months here, the children with SAD group had smaller head circumference compared to non-SAD group, and that was continuous during all the life, all the first months of life was always severe, but it was not observed in another anthropometric measures. So here is a Kaplan-Meier curve that we compare the chance of has the first seizure. And red, we have the SAD group. We can see the first seizure happens earlier than non-SAD group. So the chance you have the first seizure probability was earlier at the SAD group. This is just an example of one kid that will show the evolution of the EEG during the life of the child, and we can see a specific pattern that will change during the life until come to SAD, the seed, at the last figure. So, as conclusion, we study for the first time the relationship between SAD and neurological findings. Of course, it's a simple method study, a simple statistical method, just to show there is to highlight there is some problem related to seed, and more investigation is required about this. But this is the first study to see the relationship of SID and neurological find in congenital Zika syndrome. And its identification during the first years of life probably is associated with the horse clinical case. Identified SIDS in children with congenital Zika syndrome may motivate early intervention and adequate monitoring of severely children. Uh, at the discussion, we used the possibility of the SID corresponded to another epileptic form discharge. That is no periodic epileptic form discharge. Is a very severe condition that was never described before in congenital Zika syndrome and is very similar to SID, is a differential diagnosis. But the concern is the periodic epileptic form discharge, the PED, implies in maintenance of intracerebral damage in affected children, because we just see the PEDs in infection as, for example, herpesvirus, meningitis, trauma, uh, ischemic lesions, it's more severe conditions. And we highlighted to this possibility, but of course, new studies to investigate the possibility of the seed corresponding to PEDs is required for in all the papers, but we can prove that now, that hypothesis. And we are the first to investigate the importance of SID and congenital Zika syndrome. For future perspective, we will have a new follow-up at 8 years of age with 125 children, and we will see neurological, imaging, clinical, and electroencephalographic conditions at 8 years of age. And we'll see the mortality rate of that among the children, and see the effectiveness of new treatment that the NINA is providing for the children. For example, the use of therapeutic cannabidiol. They are using for the children to control the seizure. So new papers are coming, probably. Thank you so much for the attention. I will be available for any doubts.
Wonderful, great job. Questions or comments for Marcos and team?
This is a really interesting paper and very technical from a neurological standpoint. I just have a fairly basic question, Marcos, so maybe you can describe this. What is the functional status of many of these Zika children? Like, how broad is the spectrum, and what are their functional capacities?
Like, do you mean like the motor functional or learning function,
motor,
cognitive?
cognitive, yeah, anything, all of it.
Okay.
Yeah, all of it. How can you explain to a layperson, like, what is the impact on the life of these children? What are their...
Yeah, the children, I know a lot of children because of the project. They had a very impairment at the function, at the motor function and the cognitive functional. They depend of any activity, any daily activity, to eat, to move, to walk. Most of this don't walk, for example, and yeah, that they are very severe. And we investigated that functional, most of the motor function with the GEMINI yeah, that scale. But in all children was very harsh. I don't know if I answer your doubts.
Yeah, it sounds like they're all on the very severe side,
Yeah.
with crippling, very limited mobility. very limited ability to feed themselves, if any, and they need 100% care. When it comes to the cognitive status, do they have any language function? Do they have any ability to communicate?
Some yes, some yes.
Okay.
Some has, but I'm not sure if they was investigated with a specific scale the language, because in this paper we investigate until 36 months, and most of these don't they couldn't speak, that they didn't learn to communicate effectiveness. I don't know if with 80 years old, I think with the rehabilitation that they do a great job there with rehabilitation, with occupational, it's occupational therapy. I don't know the name. Physiotherapists, phonoaudiology, they do a great job there. But I'm not sure how is now the children, if they improve it, that skills.
Perfect. Well, congratulations, Marcos. This is a really, really impressive paper. And I also want to highlight, it really brings out a very beautiful part of the Brazilian healthcare system, that they're able to maintain these prolonged cohorts on these very, very, very sick kiddos and provide long-term care. That's a really impressive thing to do. It gives so much information to science to be able to integrate all of this very unusual findings in high-income countries and generate this data to be able to inform treatment and prevention in the future. So a big congratulations to the Brazilian healthcare system. If you guys don't understand about it, this is really, it's very impactful for low and middle income countries to be able to get this data out there, because this is where it's impacting the most. And so supporting our partners in Brazil to do this kind of work is really paramount.
Thank you so much.
Thank you, Catherine. Before we have any other questions or any other comments, I also just want to point out that we have with us Dr. Antonio Silva, who are able to join. It's a pleasure to have you here at the meeting, Dr. Silva. I want to say, one of the best epidemiologists in Brazil currently, and published very important books and papers in the area, and definitely have taught me a lot when I visited São Luís at those times. So it's a pleasure to have you at our group here. You're very welcome to join anytime.
It's my pleasure, João, to be here and to hear Marcos. Marcos is a friend, a former student, and he's a brilliant man, you know that. And it's really a pleasure. So
thank you. Thank you. You're always welcome to come, and we're eager to collaborate more. So Marcos, working with you on the paper, it's fascinating to be able to describe something for the first time, or when things are not widely described. What I was curious is there's two pieces of I'm curious to think about forward in this project. Now, the first piece is, has this kind of disease, so the epileptic form, continuous epileptic discharges, how common it is in non-disease population, typical population without infectious diseases or anything like that, just to have an idea of a comparison. And then the second one is, this study was done a while ago, so these kids are older now. What is the lifetime there? And then are you continuing to follow them on the same cohort?
First of all, thank you for joining, Professor Antonio Silva. I'm very happy you are here. I didn't see you join during the presentation, but thank you so much for being here. So, nice question, João. About the first question, how common is in non-sick population? This seed, it's not common for asymptomatic people. They are usually common in infections disease, infection congenital disease like herpes virus, syphilis, or when you have calcifications in the brain as toxoplasmosis or other kind of disease. So in asymptomatic or non-sick disease is not common, but has the seed don't means has the seizure, don't means you have epilepsy. You can has the seed in your EEG, but you don't have clinical seizure, clinical epilepsy or something like that. That was we show in that paper. Some children has seeds during all life, but don't has epilepsy, for example. There are few, of course, and is more associated with epilepsy in most cases, but on the literature, they always will highlight that seed is related to some atypical condition. But for example, the PEDS, the periodic epileptic from discharge that has the same pattern, the only difference is the continuous epileptic from discharge happens during the sleeping, the sleeping or awakeness, and the PEDS is during the when you are not sleeping. And we, on the first format of that paper, we call PEDS, and the reviewer just advised to change the nomenclature, change the word, because PED implies you have acute disease, you have inflammation, you have a trauma, you have a ischemic conditional, you have infectional, and we could prove that the children had acute disease during all the life. Nowadays, the Zika is understood like non-progressive encephalopathy. It's like you have intrauterine problem in that moment of the conceptional, the fetus formation, but you don't have the problem during all the life. It's just a sequel. But we show here the children with that kind of waves in the EEG are hoarse during all the life. Why? Why? There is something happens with the children. There is some damage that is still occurring during the life. But to show that, we need to perform magnetic resonance. I don't know the name. The school exam. We need to liquor. We need some blood test to show inflammation. But we can do that. It's very expensive to do that. So we could show that, and we change the classification for seed. But the seed just happens in who had some disease. And the lifetime, the follow-up is with the same cohort, are the same children's, but during the study, some children's joined because most of the children's was follow-up since the birth, but others just entered and they started with 6 months, 12 months, because in some cases the diagnosis was retarded, that they spent time to give the result. But now we have the information of all the children. It's the same cohort and all the time. I don't know if I answered your doubt, John.
Yeah, no, thank you.
Do you want to compliment, Dr. Antonio?
That's okay for me.
Very good. Any other comments or questions for Marcos or anyone else?
Okay, well, thanks, Marcos, very much for presenting the paper. Very nice publication. And again, thank you, Dr. Silva, for joining the call.
Great job. Let's thank Marcos.
Thank you so much.
Well done.